Many thanks for joining us for the RM Partners Future Focus webinar, and apologies for our late start. We just had a few technical issues there at the beginning. So my name is Philippa Hand. I'm chairing this meeting. I'm the Senior Nurse for Cancer Services at LNWHT University Hospital. We have two facilitators and panel members as well joining us. We've got Elaine Tomlins, who's nurse consultant for chemotherapy from the Royal Marsden, and Lorna Smith, who's acting lead cancer nurse from Kingston Hospital NHS Foundation Trust. So today we've got two presentations for you, and please do post questions in the chat during those presentations, and we will have a Q&A session after both talks. So the first presentation is going to be given by Randall Jones, and the title is Moral Injury. Randall completed his general nursing and midwifery training in his native Australia. After moving to the UK, he specialised in HIV nursing before switching to specialist palliative care in 2004. He completed his MSc in Advanced Nursing Practice in Palliative Nursing and has worked as a senior nurse for palliative and end-of-life care at LNWHT University NHS Trust since 2016. Thank you, Randall.
Okay, thank you very much to Philippa and to RM Partners for asking me to come and have a discussion with you today about moral injury, which was something up until 2 years ago I wasn't aware of at all. So I think it's a good time for us to start reflecting on how the last 2 years have actually affected us in relation to COVID. And I think especially now that we're looking at another surge and another wave coming in, as to how we can look after ourselves and look after our colleagues throughout this. So initially, I just wanted to start with a recognition that this presentation may trigger some emotional responses in people. As I said, I fully appreciate it. People have had a very difficult time, and to go bringing up stuff, especially about the first wave, which I'll speak about, upset some people. So if you feel upset at all, please seek any support from your trust wellbeing team or speak to your GP. Firstly, I just want to do a reflection on what happened locally here at London North West and about the effect that the first wave of COVID had on us. We're one of the first trusts in the UK to report COVID patients. So on the 9th of March, we had 4 COVID patients within the trust. By the 12th of March, we had 2 wards full of confirmed cases of COVID. So that was probably about 35 people. By the 13th of March, we had greater than 40 confirmed cases with 20 probables sitting on other wards. On the 26th of March, we recognised that this was an enormous problem, and our HDU, so our high dependency unit, which usually has 6 respiratory beds, surged to 20 beds. It was at this time that we actually then called a clinical incident regarding the amount of oxygen that was available. So my screen has just got that was available within the trust. So we were the first trust to do that as well, not something to be proud of. On the 30th of March, all our medical wards had become COVID positive wards. And between the 26th of February and the 19th of April, we had 100 patients admitted to HDU who were treated for confirmed COVID-19 respiratory failure, and 65% of those either died or were intubated. So we were looking at enormous numbers, and I know this is probably reflected in trusts throughout the UK and throughout the world as to how overwhelming the unknown of what was going to happen was for everyone. So this just gives you a reflection of what we were dealing with. So usual activity versus COVID-19. So these are the number of deaths we would normally see. So in 2019, pre-COVID, in March, we had 189 deaths. In 2020, with COVID, we had 343, which was an 81% increase. And then in April, things escalated enormously. So we had 450 deaths, which was a 169% increase on the year before. So we had a lot of people dying, and we had a lot of people dying very quickly in the trust. So we had a lot of deaths happening within the trust, and we had a lot of very unwell people within the trust. And we also had a lot of staff off sick. And we had members of staff who actually died, and we were having to do a mass staff redeployment. So those staff that would normally have worked in day surgery or endoscopy units were now being redeployed to intensive care unit with little to no training. We were seeing delays in cancer investigations and surgery, which may resonate with lots of people on this talk. Staff were also working within new roles, and as I said, they had no training or experience to do it. So they were being asked to look after ventilator patients. And, one of the redeployed staff I spoke to said that on day 3, she was asked to look after a ventilator patient by herself. And she had come from working in a day surgery unit. So what we did as a palliative care team was to go around and speak to staff. And we did lots of chats with those staff who've been redeployed specifically to ITU to ask them how they felt and to try and look at some form of building up resilience and to just to get an idea of what their experience had been. And the big word that came out was a unanimous sense of trauma. And for me, it was shocking to hear some of their stories and the impact it had had on them. And I couldn't quite get my head around what I was actually seeing at this time. And it wasn't until I was speaking with colleagues that we came up with the fact that this was probably moral injury that was happening with the staff, and this was the way they were presenting with it. So I quite like this slide, and it's just a time just to have a bit of a reflection that at any point during the pandemic, would any of the following words resonate with you? Did anyone feel any of these emotions during the pandemic? And normally we would be doing this, face to face, and COVID has changed that enormously. So we would get a better idea of what's going on within the group. But I can imagine that, people were angry. I'm very angry now that we're about to go into another wave. I'm feeling exhausted, and I was chatting with Philippa this morning about the fact that, staff are exhausted about having to go through this again, and the emotional impact that it's having on everyone. We were massively unprepared for what we were seeing. This was a once in a lifetime thing, and we had no idea what was happening. We were all overexposed to what was going on. We felt at risk, the risk that we were going to catch it. We're going to take it home to our friends, our families, our loved ones. Traumatized, I've already discussed. So as I said, what all of these emotions that were brought up by this, by the pandemic, is what is defined as moral injury. So moral injury was first coined in relation to the experience of military combatants during the First World War, in that they were coming back from war, and what they were describing about what they had seen wasn't a form of PTSD, but it was the profound distress which resulted from actions, or the lack of them, which violated one's moral or ethical code. So we all have our core values. We all have these values that we live by, and we have our standards, especially within, I'm a nurse, so within nursing, but I know there's some allied health professionals on here as well. But we all have standards where we work to, and they are our core values. And if those are challenged, or we have to work below those, we begin to feel out of our comfort zone, and it can leave us feeling quite devastated or disillusioned with the care we're delivering. So trauma and the distress it causes is determined from the perception of threat rather than the magnitude of events. So even though we heard a lot about the people on the front line, those who are in intensive care or those who are in ED, what we can get is that we were seeing moral injury with people, some of our cancer nurses who were seeing patients presenting late because they didn't want to go to their GP, they didn't want to risk becoming infected with COVID. So there was lots of trauma going on, and it didn't have to be the big hitting areas that was happening in. So one of our psychologists put it beautifully. She said at the time we were all in the same storm, but we were getting through it in different boats. So we were trying to come up with coping mechanisms to make sure we navigated our way through what was going on. And how does moral injury manifest? So it's changing, some people may recognize some of these changes that happened. A change in sleep patterns, a significant or persistent change in behavior or habits, making mistakes more often, feeling isolated, some compulsive behavior, and a weakened sense of empathy or compassion. And I pick up on this weakened sense of empathy and compassion because what we were seeing in intensive care here were a lot of deaths happening. And I spoke to one of the redeployed allied health professionals, and she said that she walked onto the ward one day and there was a patient who had died that she'd been looking after the night before, and the body was still in the bed. And she said she just couldn't look at it or couldn't do anything with it because she knew she would be seeing so many more deaths that night that she had to turn away and walk away, rather than showing the empathy and compassion that she would have normally have shown during that incident. So moral injury is different to burnout. We hear a bit about burnout a lot, talk about colleagues. So burnout is a psychological syndrome emerging as a prolonged response to chronic intrapersonal stresses on the job. So it is different to moral injury, because moral injury occurred during the pandemic due to an overwhelming new response. So it wasn't a chronic thing. So I imagine that burnout will probably be what will come out of the fact that we're heading into year 2 of trying to deal with this pandemic. So the concept of burnout resonates poorly with some clinicians. So we always see, say that person's burnt out. It's a negative connotation to it. So it suggests a failure of the resourcefulness and resilience of our colleagues. And these are traits that clinicians have honed during decades of intense training and demanding work. So we all think that we have built up our resilience and we all know how to work the system, but burnout is when you feel as though you can no longer do that. But burnout tends to overlook that there's failings within organisations and systems. So I would think, in the initial stages of COVID and still nowadays, I think there were several systems that were failing, and that we had no idea how we would work our way around, PPE being one example of them, and how to access them and what was the best way and what should we be wearing, were failings of the system rather than of the person themselves. So PMIEs, so these are potentially morally injurious events. So these are things that have the potential to cause a moral injury to you. So that's if you are doing something that's morally injurious. If you're witnessing something and you're not doing something about it, so you're failing to prevent something happening, or if you're bearing witness to acts that transgress deeply held moral beliefs and expectations. Just to say, moral injury is a normal thing, and empathetic people you would expect to be morally injured from what we've been through. So it is a very normal response to a very abnormal traumatic event. So I would be shocked that if people weren't feeling in some way morally injured. So healthcare perspective. So what happens in normal times? What we do in normal times is the most important thing to us is the patient's best interests. And when we see that constantly under threat because of resource restrictions, the NHS doesn't have enough money going into it, competing professional codes of conduct, doctors versus nurses versus allied health professionals, inequalities between different parts of the healthcare system, the financial considerations and failures of leadership. What we can usually do is navigate our way through those. We have, many of us have been in the healthcare system for such a long time that we know shortcuts, we know how to get through the system to be able to get to where we want to be. But while we're navigating those, we're being continually caught between what's personal and what's our professional gold standard and the realities of dealing with the system. So we'll often say, I want to deliver gold standard care, I want it to be up to a certain level, but we realise that the system doesn't allow us to do that. And I think, after the announcement about the COVID booster jabs at the weekend, you're seeing lots of Twitter conversations around, especially GPs, feeling that they want to deliver gold standard, but the system just isn't allowing them to do it and do it in the way that they would want that's best for patients. So the other healthcare perspective, for healthcare professionals experiencing the suffering, anguish and loss of being unable to deliver the care they feel patients need or deserve, that is the best care, it can be deeply painful. So when we don't achieve what we really want to achieve at the end of an exhausting shift, it can actually affect us quite deeply. And the fact that, this is why we come into work. We want to do the best for the people that we're looking after. So what are some examples of COVID-related, potentially morally injurious events? So what are some of the things that people saw, witnessed, did themselves that could cause them to be morally injured. So I think one of the biggest ones was, especially the first wave, was witnessing multiple deaths, feeling unable to change the outcomes. So as I said earlier on, people who hadn't seen a patient die for 15, 20 years were on like a conveyor belt looking after patients who were dying, sometimes multiple deaths in the one day. When we had our conversations with redeployed staff and when we went around to the wards as a palliative care team, one of the biggest issues was that, that staff had were patients were dying without relatives being present. We were so used to having a system where relatives could come in and sit with the dying patient that when we shut down all visiting and restricted it, that healthcare professionals found it deeply distressing that patients were dying alone and they didn't have the time to be able to go and look after them correctly. There was the redeployment to unfamiliar areas, and there was the fear of doing the wrong thing or being told off when you're trying to do your best. I haven't worked on a ward for 15 years now, and I can imagine if they put me into ITU, I'd be absolutely terrified of what I could do as a major worry, but also what I was seeing. There was the cancellation of planned treatments, investigations and consultations that happened. So it didn't have to be seeing deaths every day. It could be, my normal working day involves planning treatments or investigations or meeting with patients, and I can no longer do it. So it was a change in your role. Multiple competing priorities of care. When you've got a patient who's on CPAP, and then you have the phone ringing, and then you have a ward round that has to be done, and then you have IV fluids, and then you have antibiotics to be given. So there was this multiple, what can we do and what's the best way of getting through this? We saw with a lot of staff, there was a loss of the usual team support. So you work with a group of people, you get to know them, you get to know their habits, good or bad. And what you do is you have that support system in place. But what we found with a lot of the redeployed staff was that they completely lost that support system because they were placed in an unfamiliar area with people they didn't know and feeling as though they weren't up to doing the job. There was an overexposure to the cause of the distress. I'm not sure if anyone else feels this, but I'm getting a bit sick about hearing about COVID. And I think especially during the first wave, you had it at work, you went home, it was on the news, you couldn't go out because we'd been shut down across the country. So you were sort of stuck with COVID constantly being in your mind. There was the fear of contracting or transmitting COVID to contracting it yourself or going home and transmitting it to family and friends. And that sort of fed into this feeling that other team members were not pulling their weight. This idea that, at that time, within our palliative care team here, we had 50% of our staff off sick with COVID. So there was that feeling that, we've got to go and we've got to pick up the work that they're not doing. And people at the end of the day were too tired to attend or unavailable to attend debriefs. I remember going up to ITU, and at the end of the shift, there was just a lineup of people who just looked dazed going home, and all they wanted to do was doff what they had on and get out the door. They didn't want to sit down and have a debrief about what they'd experienced. They just wanted out of the building. And I said there was also that despair that the best care could not be delivered due to what was going on with the system. So what's the psychological impact of all of that? So moral injury is not a mental illness. However, it can lead to negative thoughts about oneself or others, thinking that you're not good enough, that people don't care about me, as well as feeling of the shame that you aren't reaching the standards that you would normally hope to reach. And these can contribute to the development of mental health problems, even though moral injury isn't a mental health problem. And the mental health problems it can lead to include depression, PTSD, and anxiety. So just a bit of, we would chat about this, but just to have some thoughts, and you may want to take this back to the team, just some discussion points about, have you or anyone in your team identified any experiences during the pandemic which have made you feel you have not been able to give of your best? Have you felt at any time that despite your best effort, your care has not been fully appreciated? And I think there was a lot of people who were very tired, very angry, and yes, the NHS came together phenomenally, but I think there was also a case of, lots of short tempers going on. Have you witnessed anything during the pandemic which you would not wish to happen to you if you were a patient or to any member of your family? Have you felt that you tried your hardest or been required to work outside your comfort zone? Have you felt that doing your duty still felt wrong? Even though you were doing everything you can, you still weren't achieving very much. And have you felt inadequately trained to deliver the care asked of you? So what can we do about this? So the first thing to do is to make frontline staff aware that it's okay to be morally injured, that it doesn't show them as a lesser clinician if they come to you and say, you know, I am feeling, you know, heartbroken, I'm feeling angry, I'm feeling very emotional about what's going on. They should be encouraged to seek informal support, either from peer supporters, their managers, their colleagues. And I said the difficulty with the first wave was that what we did was we took the colleagues out of the equation. So people were working away from their usual managers, away from their usual colleagues. So that led to more distress. The chaplaincy service were great during that, or other welfare provision provided by the employer. And I think, you know, especially within this trust, but I imagine in lots of other trusts, that well-being has been pushed to the forefront at the moment, to looking after the staff in our care. And it's also important to hear accounts of the trauma and moral injury in a non-judgmental way. Not to say, you know, just get over it. Everyone else works, you know, their butts off. You have to do the same sort of thing. You've just got to get on with it without allowing people time to reflect on what they've experienced. And then if informal support doesn't help, it's important that professional help is sought earlier on. And it may be difficult if the signs of PMIE become persistent and impair an individual's daily functioning. And those in leadership roles should be actively encouraged to check on their teams and offer empathetic support. And what, you know, one of the feedbacks we got, which changed during the second wave, was that, you know, we didn't see many of our leaders out and about on the wards. They're supporting the staff, and that changed enormously during the second wave. So it is important that all organisations monitor staff exposed to potentially morally injurious events, and facilitate effective team cohesion, and make sure that everyone is aware of what support is available out there. There should be psychological support for those in the frontline roles affected by COVID-19, and they should be prioritised and made readily available. And what we often see is, because we work within the healthcare system, is that lots of healthcare professionals do not go and access psychological support, because we recognise there is often a lengthy delay in getting access to it. So we sort of just think we have to get on with it. And clinicians should be aware that individuals who develop moral injury-related mental health disorders are often reticent to speak about guilt or shame, and may instead focus on more classically traumatic events of their presentation. So it's that person who's sitting in the corner very quietly that you should be going up and asking how are they feeling. Even if they bat you off, it's important that we keep asking, and just to make sure that staff feel all right. And finally, just now that I've depressed everyone, is as well as causing injury, trauma can be responsible for growth too. So I think out of what we experienced in first, second, third wave, going in fourth, fifth, is that we met new challenges. So we often finished our debrief sessions with, tell me one good thing you've learnt about yourself through all of this. So we would have, you know, an hour of people saying how emotionally traumatized they were. But at the end, you know, we would get, you know, I realise I'm more resilient than what I thought. I realise I can pick up new things very quickly. I realise I feel more confident in going back to my old job, and my confidence as a healthcare professional has improved. And I think one of the biggest bonuses is that we got to learn about MS Teams and Zoom, which is always a joy. So that's it. Thank you very much for listening.
Thank you very much, Randall. Really thought-provoking, fantastic presentation. So we're going to move straight on to Sarah Lister's presentation now. It's okay not to be okay sometimes. So Sarah's been a registered nurse for over 30 years and a psychotherapist for 15. She has combined these professional identities for the last 10 years as head of pastoral care, psychological support and PALS at the Royal Marsden. Part of this role was providing professional leadership for the psychological well-being of staff. Thank you, Sarah.
Thank you, Philippa and Elaine and our own partners for inviting me. And thank you very much, Randall, for just sharing so powerfully the experiences of COVID and particularly talking to us about potential moral injury events. Sitting listening certainly took me back to maybe some different experiences of some of those that were described. And I'm guessing that some of you that are sitting listening at the moment, it's brought back all sorts of different things for you. So before we go any further, I'd like to just invite you all just to pause for a moment. I'd like to invite you to take a deep breath in and then release it out again. I'd like to invite you just to notice your body. What does it feel like as you've been sitting? Or maybe some of you are standing. Is it a bit stiff? Are you hungry? Have you missed your lunch? Are you actually a bit tired? It's been a really busy morning. As I've asked you just to pause and think about your body, maybe you're needing a toilet break. Or maybe you're feeling a bit hot or a bit chilly. I'd like to invite you to take another deep breath in and then out. And notice, what are your thoughts after that first session? Reflecting on what you've heard. Has it taken you to what's going to happen next? Are we going there again? Is it taking you to a specific situation? Or actually, have your thoughts wandered off to this afternoon, the patients you've got to see later on, or maybe a family or a meeting? Or maybe you've just found yourself mulling over the title of this session. It's okay not to be okay. What's that all about? What does it mean? I'd like to invite you just to notice, what are your emotions? Are you feeling curious? Are you feeling a bit irritated? Are you disagreeing? Or what's just going through my mind? What are you noticing about you? Maybe some of what you're noticing, you're thinking, oh, I can't think that. I really hope nobody asks me, because actually it doesn't feel okay to feel what I'm feeling, or for anybody to know actually what I'm thinking. We live in a world, don't we, where actually not being okay in our work, in our daily life, isn't really tolerated. We've just got to get on with it. Just an example, for some reason where I live, we seem to be getting post once a week, and in many respects that's not okay. But if we think a bit further, there's something going on. We need to understand that. And that's maybe just what I'm wanting to share with you this afternoon. But actually, in life, as the last 2 years have illustrated, everything's not okay all of the time. And it's maybe to rethink that idea of not being okay and how that can be useful, how maybe it's important for us to pay attention to that. So these might be some of the feelings that you just recognise that you're feeling actually at the moment. Maybe there's some sadness there, maybe there's some irritation, maybe there's some anger, maybe from frustration, maybe feeling overwhelmed. But are those the things that you'd notice? Or if somebody really asked, or the word that we bandy around quite a bit is just that we're stressed, maybe that's a term that we are allowed to actually use in terms of what's happening. Is it? Is that what wellbeing's around, about stressed? I could spend all afternoon just unpacking that word and talking about what stress means and what role it has for us us as healthcare, us in respect of our clients. Some people say it's a helpful term, it keeps us going with adrenaline, or others that actually things have just gone actually too far. Robbins and Shoei, way back in 2006, some authors that some of you might be aware of, said that actually as healthcare professionals we become stressed when we absorb more disturbance, distress and dis-ease from our patients than we're able to process and let go of. So it's a fact. Stress is part of our work, but do we acknowledge the disturbance and the distress and the dis-ease from the people that we're working with? In the popular press, there's a lot of talk about mental well-being out there in society. I was reading something the other day that said there's been so many online courses and things like that that sometimes you talk to your friend and they come up with all the jargon. They can offer you actually all the theories actually of what's going on. And one of those trends, to a certain extent, has been thinking about a real positive approach, that one of our ways of coping is to be positive. And I certainly hear that quite a bit from patients, that I've got to keep positive, because if I don't keep positive, then actually my cancer is going to come back or it's going to get worse. So we seem to have got to the point where our emotions are put into two groups. They're known as negative or they're positive. Normal, natural emotions seen as good or bad. And almost the positives become a new form of moral correctness. I'm even wondering in your own organisations, and sometimes I hear it with managers about, I've got to be positive. That's what's wanted. We've got to keep the staff actually positive. What impact does that actually have on us on a day-to-day basis? So maybe to say I'm stressed is acceptable, but what about other emotions? Feeling overwhelmed? Feeling sadness? Randall mentioned maybe the shame and the guilt, that actually maybe it's not, I feel awful that I can't cope or that I need to go off because I'm letting my colleagues down. Or maybe some of the things that I've heard is that, but I haven't been on the front line. I haven't been working in an environment and a ward, a department where we've seen lots of people with COVID. So I shouldn't be complaining actually about this. I shouldn't be complaining about what's going on. So there was a guilt there that actually came up at times. I don't have anything to complain about. But on the other hand, I've also heard staff say to me in different ways that actually some of what's been going on, I can't cope with any longer. There is just too much sadness there. I don't quite know what to do, but I can't really talk about it. So I'd like to suggest that a term coined by a psychologist who spent her life work actually in America is that one of the things that we often experience and we often find is that we have quite a rigid approach to our emotions. And these, in case you're wondering what this image is actually a lot of palm trees who are all supported by lots of wooden poles to keep them upright. And I've deliberately put this picture in here because it reminds me of some of the ways that I think resilience is actually talked about, that we've just got to grit our teeth, stand firm, dig our feet in and just actually carry on. That's what resilience actually is. And that's why resilience is becoming a bit of a term that people don't want to talk about. It becomes almost seen as a bit of a sheep dipping exercise. If you've gone on that course, you'll be able to get through whatever. So I'd like to just talk about this in respect of rigidity, actually in respect of our emotions, actually a bit more. suggesting that there's almost been an unwritten rule book about emotions and how we connect with them and how we talk about them, that maybe we learned in childhood, or maybe we've learned in our organisations, met in the workplace, met in respect of how we respond to our patients, what's expected. But we need to reassure, we need to be bright, we need to be positive. We need to focus on positive things. But I'd like to suggest to you, as David says, that our focus on positivity and the happiness that we're all encouraged to aspire to, so making sure that we don't moan, that we can talk ourselves out of a bad mood, that to smile it is actually, in the longer term for us, actually not helpful. I've been thinking, what on earth is she talking about? What is actually going on here? Well, we might find ways to try and booster ourselves, to keep ourselves going with our emotions in whatever way that we actually do that, by trying to push them away. Trying to just think, no, I've got to be focused, I've got to focus on the good things. Like to suggest that it's like taking a paracetamol to cope with a headache, when actually we really need to maybe think a little bit more about what the cause of the headache is in the first place. Is it lack of sleep, or is it not enough to drink, etc.? But of course, if we're working, just taking our headache example, we can only think of the causes if we know that we've got the capacity and the space to actually address them. Otherwise, taking that paracetamol is just going to help us actually get through the day, and that's sometimes what we need to do. So what I'm talking about here is much more of the longer term thinking about our emotions and how we respond to them. Something that David talks about is learning to become emotionally agile. And one of those things is about admitting that at times we're not okay. But there might be a reason for our anger, there might be a reason for our anxiety, a reason for our sadness, our irritability, and it's a legitimate reason. And Randall has really helped us talking about this by recognising and giving a name for it, the moral injury that maybe we are actually experiencing. So David wrote why pretending to be okay is not okay, and she said that she's had hundreds of people tell her that they don't want to feel. They say things, I don't want to try because I don't want to be disappointed, or I just want these difficult feelings to go away. She suggests that if we turn away from difficult emotions, it actually undermines our ability to deal with the world as it is, and it's the world that we're dealing with every day. So I know that sometimes we've been thinking, well, this Christmas will be different to last Christmas, we can get through it. So we're looking towards the future, we're being hopeful, we're being optimistic, and there's nothing wrong with all of that. But when the world changes and things come crashing down, then it doesn't work actually as well and can make it much harder. So we can inadvertently make our emotional discomfort worse by something that in psychological terms is called experiential avoidance. So we take steps to control or reduce distress in the short-term relief. We turn away from it. We have that extra gin and tonic, that extra glass of wine, or we lose ourselves in that box set and we see just another episode just to try and numb ourselves and disconnect ourselves from some of those feelings. We don't talk about what's actually going on. Maybe we withdraw, we don't want to actually go out. So then what happens? Well, from a neuropsychological point of view, things actually happen with the longer term, which lead to what Rand was talking about earlier, which some would say is burnout or compassion fatigue. So one of the first things that sometimes happen is the more and more we push difficult feelings out of the way, the more dominant they can come in our mind. So that is a beautiful piece of cake. And for those of you that have been on a diet and have got a lovely piece of cake and you're just trying to avoid it, and it's sitting in the fridge, the more and more you try and avoid it, the more and more it wants to get your attention. So in the same way, if we're feeling really angry at something, the more sometimes we push it away, the more it will actually get our attention. Or maybe some of the other things that we have just noticed is that we're noticing that we're getting all sorts of body aches and pains. So our emotions have what we call somatized. They've turned into physical, actually, experiences. We don't necessarily register them as feelings and emotions that we're wanting to work through. I went through that personally a couple of years ago, where I had the most awful problems actually with my neck, and it was a difficult situation that I'd been involved in, and it was only afterwards, when I allowed myself to talk it and work it through, that I realised what the cause was actually behind that. I just tried to avoid it. Or maybe it's rumination, and we just can't get, and our minds go into overdrive all the time, trying to come up with solutions, trying to find our ways around it, trying to look at what we've done wrong, trying to come up with solutions, and they preoccupy us so that we notice that we're not concentrating in the same way. So that then leads to the fourth thing that I'd like to share here, which is something called brownouts. You might think, why on earth have I got a photograph here of somebody sitting on a horse backwards? Well, it's because of an illustration of a situation where I found myself in. I ride, and it used to be a real important part of my self-care was to go riding on a Sunday afternoon. And one Sunday afternoon, I'd been sitting contemplating something and so thought of it, suddenly realised, oh help, it's time to get to my lesson. But I really wasn't paying much attention and concentrating. Took my horse out to the ring. I realised I got the head of the horse in totally the wrong direction. For the way to me get in was mean I would have been facing backwards. And for some of us, we must remember things like, why on earth have I suddenly put the kettle in the fridge? Or why am I carrying the empty bottles upstairs, the rubbish? What am I doing here? We've got so preoccupied with what's going on that not concentrating with all the emotions that are going on. We've browned out. We've just totally lost contact, actually, in terms of what's going on. So just coming back to, let's just owning and recognizing that it's okay to realize what's going on. The expectation that we can be immersed in suffering and loss daily and not touched by it is as unrealistic as expecting to walk through water without getting wet. So hopefully I've convinced you that it's okay to not be okay. But so what? What do we do about it now? And when and how do we do this at work? This isn't about, okay, everybody should be shouting at each other and getting distressed. It's not an excuse in that respect, but it is about encouraging you to move from emotional rigidity and saying those emotions have no space here, but to be thinking about emotional agility, being a bit more flexible with our thoughts and feelings about things, giving permission maybe inside to disagree, maybe permission to think, well, actually it's okay for me to be really sad or really cross, loosening up, being a little bit more intention about what we're doing. It was Viktor Frankl, who was a psychiatrist in the concentration camps, who realised that one of the things that he did have power over in very difficult circumstances was to be able to choose his response through emotions, between the stimulus, so something that makes us think or feel, and then how we actually respond to it. It's the space that we have the power to choose. So how do we do it? Well, one of those is about allowing us at times, allowing ourselves to be vulnerable. Brown, who some of you may have heard about, Brené Brown, has written a lot, very popular, a social worker who really started exploring some modern day research, really encouraged us all to be about vulnerable with each other. And she very simply defined being vulnerable is just to feel, to allow ourselves to feel. Some of you may be very familiar with the boy, the mole, the fox and the horse, and this is one of the illustrations in it. And I think this maybe sums up what we're talking about. When have you been at your strongest? Asked the boy. When I've dared to show my weakness, is the horse's reply. So how do we do that then? Well, this echoes some of the things that Randall said to us earlier. But one of the first things that I just might want to offer you to actually have a think about is actually journaling. Your immediate response might be a bit like mine is, I don't have time to do anything actually like that, and reflect and write it down. but a psychologist called Pennebecker, quite a number of years ago now, found that just by writing, not for anybody else, but it helps to recognize and connect with some of our emotions, some of the things that we're not feeling okay about. Maybe encourage you. One of the things you might want to take away here is to give yourself just time for 20 minutes. Set a timer, either with a sheet of paper or maybe on a computer screen, and just write. Don't worry about spelling, punctuation, anything like that. Just write down your emotions and your thoughts about actually what's happening, what's going on. And then if you've written it on the computer, close the document without saving it, or just throw it away. If you've written it up, screw it up. The next one I call running and remembering. We're not, as I start at the beginning, we're physical beings as well as emotional beings, and everything is all joined up together. If you're not a runner, then we could call it walking and wandering. Really encourage you to just think about some of these difficult events. When you're out physically running or physically walking, you'll connect your emotions to your bodies, and you'll just allow yourself space to actually process it, to let it actually be. Another place maybe to practice vulnerability is what we call a professional greenhouse. I know some of the first things that always come to mind when I think about greenhouse is that it's about somebody inside throwing stones, but actually in this place I'm really thinking about the greenhouse is a place that you're protected, where you can actually be nurtured, protected from the weather of the clinical environment, the patient distress, somewhere where you can just check in with each other, where it's okay to go in and say, that was absolutely awful and difficult, actually that consultation, or that person out there is just really winding me up actually for these reasons. And then last but not least, reflective supervision. Again, as Randall's talked about, a formal space where you are prompted to tell your stories and your experience in a very deliberate way of some of the things that are difficult. For those of you who are interested in neuropsychology, we know that the hippocampus, which is a really tiny bit of the brain, which absolutely helps us process our memories and puts them to bed in the prefrontal cortex, actually when we're really stressed isn't able to do that. But by then going to a calm, relaxed environment, safe environment of something like reflective supervision allows that to happen, so they don't reoccur to us in our dreams and things like that. So I'd just like to leave you with this self-care permission slip. Take it away. As pouring from an empty cup is impossible, refilling it is mandatory. So knowing that it's okay and necessary that you take a moment, take a breath, and listen to what your soul and body need in order to continue offering the world your excellent, caring and giving self. Maybe just take away another illustration from Charlie Maxey. Asking for help isn't giving up, said the horse. It's refusing to give up. So thank you very much for listening.
Thank you so much, Sarah and Randall, for really thought-provoking sessions there. My mind's all over the place listening to that, and I'm taken back to a particular compassion fatigue moment that I had maybe 3 years ago when I was in clinic inviting somebody to care and share with me. And I remember very clearly sitting there thinking, I don't care what you're telling me. I just wasn't in the room with them, and it was a real message for me. And that message that you put up about you're strongest when you show your vulnerability, I took myself away. I had a month off, re-energized, came back stronger than ever. But it was an awful moment for me, just sitting there thinking, I'm not interested in what you're saying. There's a question on the chat that's come through. I don't know which of you might be able to answer it, which is about get my words right, emotional agility and emotional intelligence. How do they sit together, or do they sit together, or are they contradictory? I don't know, Sarah, perhaps do you want to take
Yeah, certainly. I think the part of the two phrases that they share is the word emotions, but they're different. So emotional intelligence is much more about just being aware in its definition of how we come across to other people. So it's about reading the situation, recognizing what's going on, being able to put ourselves in their shoes and see what's happening. So I would suggest, and Randall too suggests otherwise, but emotional intelligence is about reading situations. It's outward focused. The emotional agility to begin with is about beginning to recognize us and being to know ourselves where we are and being able to give ourselves permission to be a bit flexible. So they've absolutely got an interrelationship.
Okay. Randall, do you want to comment?
I agree totally. I think that emotional intelligence as well is not only reading a situation, but reading your reaction to that situation. So having the knowledge of yourself that, as you pointed out, when you hit that wall and, you had the emotional intelligence to recognize you had to walk away, that by you continuing on, you were just going to burn out more and just feel, be of no use to anyone, especially to yourself. So I think the emotional intelligence situation, but also how you deal with that situation.
Thank you. And the it's good to hear about moral injury and to know that it's normal, I think, because we all have stories to tell and aspects where I think we are clearly injured. And I just wondered, talked about this mismatch of expectations. So we have the media who's currently raging up a frenzy about vaccines. We have the NHS, the NHS, which we all get blamed for because we work in the NHS. We are part of the NHS, and the government telling us another thing. The messaging comes to hit us, doesn't it? When we face at the coalface, and it's sometimes really, really hard, isn't it, to pull all those strands together to even be coherent sometimes in what we're doing.
And I think we saw that a lot, especially after the first wave, where nobody really knew what to expect. Of that, the mixed messaging and us having to, we weren't sure what was going on, yet we were expected to be explaining it to other people as to what's happening and why weren't we letting families into hospitals or areas. Why wasn't there a GP visiting us? Why, and that, I think what I saw was a lot of anger about the messages that were being sent out and the expectation that the NHS was sorting it. And I think, I got, I'm a bit cynical in my old age, but I think I got a bit annoyed with the clapping after a while. It was like, it's a lovely gesture, but really.
Yeah, it's certainly heroes 1 minute, villains the next, isn't it, in some cases. Lorna, do you have any questions your end?
Just one, if that's okay, to Randall. Do you think Schwartz Round is quite a good platform for healthcare professionals to talk about potential moral injury? Because I've never used that term before, but listening to your presentation, I think that's a term which I could probably say has been discussed many times in Schwartz Round.
I'm the lead for Schwartz Rounds in our trust, so yes, I'm a big advocate for Schwartz Rounds. I think they're a great opportunity to get staff together. I think the difficulty with COVID is that it means we've had to switch to an MS Teams Schwartz Round, which I don't think has the same emotional impact or connection that when you're in the room with all your colleagues and be able to feel the emotion that's going on in the room, how powerful that can be. But I think Schwartz Rounds are a great idea, and there are lots of downsides as to people self-select to go to a Schwartz Round, and some staff find it more difficult to go than others. But I think they're a great avenue to discuss and to recognise that you're not the only one going through a situation.
Thank you. Thanks, both.
Thank you. I'll hand back to Philippa because I think we're just at our time. Thank you, everyone.
Yes, absolutely. I mean, I purposely let it go over a little bit because of all the technical issues we had at the beginning. And I think they were both really powerful talks. So thank you both very much for presenting today, and I think it's really quite timely before Christmas, and maybe hopefully some of us spending time with families and just having time to reflect a bit more in between the joy of work. So I'd just like to say thank you very much to the speakers, facilitators panel for taking part today. These monthly webinars are going to continue. We're going to have none on January just because it's quite a short month with the Christmas and New Year week time. So if anyone does have any suggestions though about future topics, please let us know by putting them in the chat. Otherwise, I'd like to wish everyone a Merry Christmas and a happy and healthy 2022. Thank you very much.